overreactivity. I think that you can't say for sure if it will be as successful, but you would want to just explain that it's not treating like every single incontinence problem and it's treating the one. So I don't know beyond that.
Yeah, I mean that's right, and I think also that this sling, it's possible. I don't know, Dr. Saluki can answer it. Can increase chance of now new onset. Obviously, new onset overactive bladder. She's had overactive bladder already. She may.
Dr. Siegel, right in the middle of speaking, you muted yourself or somehow got muted. There you go. That's it.
Can you hear me now?
Yes.
Yeah, sorry. No, it might actually increase her chance of overactive bladder becoming a major problem if she already had it pre-existing. The sling, I believe, can increase the chance of overactive bladder de novo, even if they never even had overactive bladder beforehand. But I think that has to go into the counseling. She may require medications anyway, unless I'm wrong.
No, you're completely right. So that is part of the counseling. Whether they have overactive bladder or they don't, if they have overactive bladder, I counsel them that most likely the sling is not going to help and may worsen the urgency, the frequency, and sometimes that subsides. A few months later, like that worsening can improve as the inflammation goes down or the bladder adjusts to the presence of the nearby sling. And then I also counsel patients who don't have any overactive bladder that they may develop more urgency, more frequency as a result of the sling. And once again, that same phenomena of it may calm down or you may need medications for a short period of time, or this may be just like a permanent feature. And then I also remind them there's many patients that walk through the door and tell me, oh, I had a sling 15 years ago. It stopped working because they developed overactive bladder due to just other risk factors. So there's a lot of counseling on that maybe 15 years after the sling, they may develop overactive bladder, which is a completely different issue. And it doesn't mean that the sling is not working. So lots of counseling can do on that. And you're completely correct. Yeah.
Dr. Lin?
Great presentation. My question is, what would happen if the patient failed her void trial afterwards? What would be the next steps?
So then if she had failed her void trial, you would get imaging, like a CT urogram, to see if there was any abnormal findings, and you could do a repeat indwelling Foley catheter and have her trial again if it was normal, versus if there was a further injury or if it hadn't healed, you might need some sort of repeat operation done to repair where the injury was.
What's the repeat operation?
Well, depending on if her bladder injury was still, it depends if she would need her dome repaired or if she would need to get a stent placed. It would depend.
What if there was no injury? What if there was no injury? Let's say, ignore the bladder dome. The bladder dome's fine, the bladder's fine, and she still has retention.
So Dr. Lin is not asking you about a problem with the bladder injury. She's asking you about a patient who gets a sling and then fails her void trial and is in retention.
Right. You would keep the Foley in place and have her try again.
And if she fails that still?
Well, go ahead and give us the answer, Dr. Lin.
I don't know. I haven't done yoga in a long time, but Dr. Saluki might know more. But you would, I believe, you would release the sling. Is that correct, Dr. Saluki?
Yeah, I'm getting flashbacks or mock whirls. So
yeah, it's oral
yes.
board question.
Yeah, no, I remember that. You did well. Yes, you have two options. Really, I'll be quick. So if it's a really bad retention, not peeing, a drop, like within like those like first few days, you have the option of either let her have like intermittent straight catheterization or indwelling catheter, and then every week or so repeat the trial avoid, or see if the quantities go down with the intermittent catheterization, she's able to void more spontaneously. But let's say you're within that 2-week period, you still have the option before the sling scars down to go back to the operating room and release the sling. You're not cutting anything, you're just kind of identifying that space between the urethra and the sling and just pulling on it, so it's a little bit more relaxed. Alternatively, if it persists at 6 weeks, by then the sling would have scarred. What you can do is you can just cut the sling, not even a portion of it, you just incise it. So that should take some of the tension off, because it's really meant to be in placed in a tension-free manner. So those are your 2 options, one of the 2. 3, if you count the catheterization.
All right, well, thank you, Vaish. Thank you for that great presentation. 2 interesting cases. But now it is time to switch gears and get ready for grand round. So in just a minute, I'm going to ask Dr. Rosenfeld to introduce our grand round speaker. But in the meantime, with regard to attendance, we'll be taking attendance using the participants list of the Zoom. If your name is listed clearly, then you'll get full credit for attendance. If your name is not listed clearly, or if there are 2 people at the same computer, you can email your attendance to Michelle or Beth, or if you are a student, to Millie. And with that, Dr. Rosenfeld, are you ready to introduce our speaker?
Yes, good morning, everyone. I am pleased to introduce Itamar Futterman to present Grand Rounds today. Dr. Futterman was born and raised in Israel. Following his military service, he completed medical school at Ross University. Dr. Futterman was my co-resident at New York Medical College, where he served as the educational chief. After residency, he completed his maternal fetal medicine fellowship at Maimonides Medical Center. He stayed on as faculty and is now the director of complex obstetrical surgery and associate program director of the MFM fellowship. At Maimonides, he has developed a robust ACRETA program, and he has published 24 manuscripts and won numerous teaching awards. His research interests involve placenta accreta spectrum and the use of artificial intelligence in clinical obstetrics. Please join me in extending a warm welcome to Dr. Futterman.
Good morning. Thank you so much, Dr. Rosenfeld, for that introduction. It's so nice to see you. It's a pleasure being here this morning. I hope to be able to share with you what we've done at Maimonides over the past couple of years in creating a obstetrician-led surgical care program for placenta accreta spectrum. I have no disclosures. These are a couple of our objectives for this morning. We're going to start very broadly by defining PAS, how we diagnose it, discuss ultrasound markers, and then we'll dive in a little deeper into the challenges around PAS-related research and care, how we define morbidity, and then really focus on the efforts to identify risk factors that increase morbidity and what we've done in Maimonides in terms of creating a COS program, and how that has pushed us into finally creating a conservative management protocol for PAS. So we'll take a step back. Placenta accreta spectrum, everyone has heard of it, has hopefully most of us have seen it in the OR, but it really is a spectrum of disease ranging from completely normal placentation all the way to what was previously defined as placenta procreta. There are obviously now alternatives to that with several grading systems, the most famous of which is the FIGO, which we'll talk about in a minute. In terms of incidence and rates of placenta accreta, so if we go back in time 40, 45 years, we're talking about something pretty rare, 1 in 1,250 pregnancies here in the US. And that, if you think of those numbers for a minute, that really means there are hospitals and institutions in the country that almost never saw it, or if they did, it would be once in a decade or so. now we're at a point where most accreta researchers are talking about a rate of probably around 1 in 250 by the year 2030. And that obviously has to do with rates of rising cesarean birth, IVF, and several GYN surgeries that may be predisposing to placenta accreta as well. So 2018-19 FIGO committee comes together. Majority of the people involved are accreta surgeons. About half of them are MFMs. And they come up with this grading system of grade 1, 2, 3, A, B, and C that delineate the degree of abnormal placentation. 1 and 2 really, I think, correlate pretty well with accreta and increta, the old terms, where the per creta ones were divided into A, B, and C, depending on the extent of invasion to the surrounding structures. The idea behind this was, I think there were several goals in creating this FIGO's scoring system. And talking to some of the people who are on the committee, I think it was an idea to kind of push people to think about accretas in a different way. Not all accretas are created equal, and therefore the surgical care for accretas should differ between the grades. That has yet to really take off, but that was one of the purposes of creating this grading system back about 5-6 years ago. In terms of ultrasound markers, I think all of us are pretty familiar with them, but I'll go over some of the more famous ones in a minute. I think it's pretty amazing what the leaders in this field have done, specifically Dr. Itamar at NYU and Dr. Dar at Montefiore and several others, where they have brought the level of sensitivity of ultrasound detection for PAS to about 90 to 95%. Of course, the caveat here is that this high degree of sensitivity for detection comes in the right setting, meaning a tertiary care center that is well trained in placenta accreta spectrum ultrasound, with high level of technician performance. That is unfortunately not the case everywhere, and I think this is probably where some of the downfalls of ultrasound are. With that, we have emerging evidence for first trimester ultrasound that we're still kind of processing and trying to understand. And our population is becoming heavier with a larger BMI on average, and that on itself is a big limiting factor for ultrasound sensitivity as well. I'll start with first trimester ultrasound. This is a publication by Dr. Itamar almost 10 years ago at this point, and I use this routinely for our first trimester ultrasound scans. At this point, there's a bunch of lines on the screen, but at this point, I think it became kind of second nature. When I look at a sagittal view of a uterus with a first trimester scan, the first thing I do is I kind of divide that image in 4. And I ask myself, where is the pregnancy? And if you look at the first image, anything above that dotted line and behind this dotted line, meaning it falls in the area of B or maybe even C, is something that needs to be investigated, and make sure it falls into the right hands, both sonographer and qualified MFM. Because if a pregnancy is falling in this region of the image, there's a very high likelihood that pregnancy is a cesarean scar pregnancy, which would predispose the pregnancy to becoming on the spectrum of accretas. So you can see the first image is a normal pregnancy, normal placentation, up near the fundus, communicating well with the endometrium, where the second image, you can see that the pregnancy is falling right at the edge of the bladder on the ultrasound, which is really, I think, the best clue to cesarean scar pregnancy, yes or no, because the edge of that bladder is where you made your incision, it's where your niche is, and that is the area where the pregnancy may attach and eventually become a full-blown accreta. Images here are a little bit small, but Dr. Dar at Monty, Dr. D'Oliveris and Dr. Dar at Monty last year published this review paper on first trimester ultrasound diagnosis for cesarean scar pregnancies. They call it placenta accreta spectrum in the first trimester. And I think they added something very, very valuable, which is the discussion of the CIC, or the cervical isthmus complex, which really didn't get a lot of attention here in the US, but is something that was discussed for probably the last decade or maybe even more in several areas in Europe. And what they point out to is that a lot of times ultrasounds are misread as cesarean scar pregnancies because people don't take into account these muscular bundles that you can see here, I think better on the second image, which represent an undeveloped lower uterine segment. So someone may see this first picture and say, oh, the pregnancy is very low, I think this is a cesarean scar pregnancy, really not accounting for this 2 or 2.5 centimeters of low uterine segment that have not yet developed, and the niche being behind it right there at the edge of the bladder. With the pregnancy being so far away from the niche, the possibility that this is a first trimester accreta becomes almost non-existent. So just a kind of a side-by-side view here, same author, same paper. I think they did a nice job with the illustrations as well. Again, you can see these muscular bundles in the lower uterine segment. The niche is right there at the edge of the bladder, and the pregnancy is implanting far away from that. Where here, if you look at the edge of the bladder, this is the niche, this is the pregnancy. Now you can see that the pregnancy actually embedded itself in the niche, and therefore it has a very high likelihood of becoming a full-blown accreta. Again, I think they did a nice job summarizing the ultrasound markers here, but a low gestational sac with implantation in the niche, or placenta that penetrates the niche, you're talking about anywhere from about 70% to 100% sensitivity for that pregnancy to become a full-blown accreta. These, I think, are the more common markers that we use. They're really meant, or I would say that a little differently, they haven't been fully investigated as good markers for first trimester, and they're really meant for second trimester, I would say second half of the second trimester or third trimester ultrasound markers for placenta accreta. So we have our placenta lacunae, we have our retroplacental hypervascularity. Again, we have to be careful with our ultrasound settings here. You can very easily decrease that flow sensitivity, make everything light up. So we have to be careful with that. But on the right setting, the retroplacental hypervascularity is a great marker to kind of see what you're dealing with. And then we have our myometrial thinning and our loss of hypoechoic zone, that dividing hyperechoic strip on the ultrasound, dividing the myometrium from the placenta. In these cases, it's lost, which is, again, I think, a great marker for placenta accreta. Researchers that have looked at these markers talk about, each of them and that marker's ability to really predict the presence of accreta. Obviously, they're all good. You could see them here. But I think what has captured the attention of most researchers is that really it's the lacunae, both the size and the number, that should get you thinking about a possible accreta. So now a little bit about the challenges around placenta accreta related care and research, and they really go together. So the first thing I want to kind of highlight is when we're talking about accretas and we compare it to other diseases, accreta has been heavily under investigated, even though the first reports of accretas are coming out probably, as far as I know, around the 1920s. There may be earlier descriptions of a morbidly adherent placenta a little bit before that, but the first kind of widely accepted medical journal publication discussing accretas are almost 100 years ago at this point. And yet the research around it really didn't take off till about 10 or 15 years ago. So I'm going to go through these. And again, I think some of these topics are somewhat sensitive to certain providers and certain people. So I mean, no disrespect. This is just an overview of the challenges that we were able to kind of jot down and try to tackle one by one. And that's the purpose of sharing them with you here today. So really the first one is gaps in training. There's been several publications over the past couple of years. I think the big one was 2023 by a group of very famous accreta surgeons who are all MFMs in training from around the country. They published this really fantastic review about different levels of complexity for cesarean delivery, what should be in the room, who should be in the room, who should be doing the surgery. And in this review, they make I think a very bold statement that is based on very little research, but I think is a consensus among most training programs in the United States. And that is that training in complex obstetrical surgery, specifically placenta accretas, is lacking among graduates for many or most residencies across the United States. Another group working out of South America and Colombia, Dr. Niero Calvecchi, he actually went and tried to tie this lack of training to the maternal mortality cases around PAS in his institution. And what he found really highlighted the need to improve training and improve instruction regarding placenta accreta. So these are cases where there was a maternal mortality, and they found that in 75%, 75% of the cases, it was either that a interdisciplinary management wasn't carried out, or the operator felt inexperienced or was deemed inexperienced to handle such level of surgical complexity, which unfortunately led to inappropriate bleeding management during the case. So a decline in surgical confidence among obstetricians, which has been described by two authors in the past couple years, really focused on the lack of experience and the inadequate surgical skills of many obstetricians. And that really is highlighted when we're talking about higher level of surgical complexity. So the first author I mentioned here, Jem, did I think a really nice job in going through and surveying providers and asking them how confident, first of all, if they've been involved in higher level surgical complexity cases, and if they feel confident performing this procedure. So among those that answered not confident, almost 80% actually were involved in the management or the surgical management, assisted in the surgical management of cesarean hysterectomy. Yes, yet almost 80% of them still said they were not confident in performing these procedures. The numbers are slightly lower, but still, I think important to note, a repair of a ruptured uterus, internal iliac ligation, and dissecting the ureter. So all these higher level complex cases, people, even if they attended and assisted, still left training feeling not confident in performing these procedures. The other issue we noted around both care and I think a very important limiting factor to research is the lack of identification of the risk factors that increase surgical morbidity in placenta accreta spectrum. So last year we, as part of the New York City MFM Research Consortium, we took a different approach. We had a database of about 400 plus cases of accretas among 5 tertiary care centers around New York City. And we took our database, which had, I want to say, almost 220 different variables, ranging from demographics to outcomes. And we were able to work with a startup that does machine learning analysis. And we wanted to basically ask the question of, why do some people end with a blood loss of 12 liters, an ICU admission, multiple blood transfusions, and some are able to go home on post-op day 3 with a blood loss of 1,000? So I'll start on the left because I think it kind of puts it in perspective that this machine learning algorithm actually had a pretty good performance with an AUC of almost 0.8, which I would rank that as mild to moderately good in performance. And then when we look at the variables that were included of being the most influential or most important in predicting surgical morbidity, aside from patient BMI and the degree of prenatal care, it was actually the completion of the hysterectomy that put the patient most at risk for surgical morbidity. And when you see it this way, I think when we were done with this analysis and we took a step back, we asked ourselves, okay, what is next year? How can we turn this around? We all want to do right by our patients, and yet it feels like we're banging our head against the wall saying all accretas need a hysterectomy. Alongside this analysis, we were successful in publishing another paper with the consortium looking at, and this is shocking that this is only happening in 2024, considering we've known about placenta accreta for almost 100 years, and considering that OBGYN research is so heavy when it comes to health inequities. This is the first publication that asked the question about health inequities in PAS care, as far as we know. No one has taken a step back and said, what do outcomes look like across race, ethnicity, zip codes, levels of education, etc. And with a population here of about 30% white, 30% black, 30% Hispanic, and the rest were other races and ethnicities that were included in the study, I think a good distribution among the races and ethnicities showed us that there were no differences in both maternal and neonatal outcomes when it came to placenta accreta care. So that's a positive. I feel like that's not something we always see in OBGYN, but this was I think an important first step to start the conversation about health inequities when it comes to surgical care for placenta accreta. The third question we asked ourselves as we were building this program is, can the morbidity be mitigated by the surgeon? And what is truly the role of the GYN oncologist on L&D, and especially when it comes to placenta accreta spectrum? So GYN oncology presence on L&D, as we sat down, and I'm going to share our publication about this in a minute. And it's important to note that one of the co-authors is a GYN oncologist. And I think, we were all on the same page that GYN oncology presence on L&D is a double-edged sword. Obviously, it's a tool for patient safety, but it's also a track for surgeon burnout. And I take away that question mark because it's not a question. Are GYN oncologists being called at 3 a.m. to perform a cesarean hysterectomy is a track for surgeon burnout. Majority of them, and I'll show the data in a minute, don't want to be there at 3 a.m. to do a cesarean hysterectomy. Another question that came up was, is it a barrier for research? Is it part of the reason we haven't been successful in diving into the research around morbidity for placenta accreta spectrum is because the people who are performing the surgeries are GYN oncologists who are then going back to their office with 40 patients waiting to see them, and their own projects, rightfully so, that focus on cervical cancer, uterine cancer, whatever their passion is. It's most likely not accreta. And it is probably a barrier to why we are only starting the conversation around surgical morbidity and how to improve it in the past couple of years. And finally, are they really needed at every obstetrical hysterectomy? If it's not a accreta, or even if it's a certain type of accreta, is it okay to say, I don't need the GYN oncologist here unless there are certain things that happen during the hysterectomy where I may need another set of experienced hands? That's I think a question that took us the longest to kind of hash out and iron out, and how to do this in a safe way for both the patient aspect, but also respecting the time of our GYN oncologist colleagues. And again, before I show the data, I want to make very clear we're so grateful for our GYN oncologist colleagues coming in, helping out, and none of this is meant to say that we don't appreciate them. It's simply, I think, laying the facts that right now they are pulled in to labor and delivery to come in and do that final procedure where the uterus is removed. And the idea here is to challenge that, considering we've all been trained in open hysterectomies. So a couple publications, again, not a lot of data out there, but a couple that really focused on, first, how often is this happening? And second, what is the level of interest of the GYN oncologist when it comes to placenta accreta care? We're talking now about 80%, I think in areas of the country, this is probably even higher. 80% of cesarean hysterectomies are led by or involve a GYN oncologist. And when we looked, and not myself, but when co-authors looked at the level of interest in PAS care when it came to GYN oncologists, almost 50% of them said that they really have no or little interest in obstetrical hysterectomy. And the numbers here, I think, are very interesting. When GYN oncologists, first of all, when they were asked if they've experienced blood loss of greater than 5 liters when it came to PAS, almost 75% of them said they've had between 3 and 5 cases of more than 5 liters blood loss. 33% have had more than 10-liter blood loss. When asked about conservative management, do any of them practice it? Almost 40% of them say, almost 60% of them say no, they do not. And again, going back to these barriers in care and research, when the lead surgeon is not an obstetrician. Do Do they practice delayed hysterectomy? Again, 60% say no. And these are just some of the more common ways to practice conservative management, which have had mixed outcomes in terms of ability to decrease morbidity. And finally, do they have interest in performing hysterectomies for PAS? And almost 50% of them say no. So if obstetricians are not performing the hysterectomy, and this is where we kind of took off in terms of our initiative, who will then investigate, conduct peer review, and ultimately draw conclusions for improvement? So this pushed us to call the group of obstetricians in our institution, give us a name, give us a mini division where these complex cases would be funneled to us, specifically to myself as outpatient, and then work with my 3 colleagues who mainly do inpatient care, who are all laborists, and really divert the complex, the extremely high BMIs, the myomectomies that needed to be performed during cesarean delivery, and of course the PAS. At least to start, those cases were funneled to our group with the idea that we can handle 99% of the load without calling a GYN oncologist. But of course, we also drew a line where we knew if there was a certain type of case, a GYN oncologist would be called into the room. But that we went from 80% involvement of GYN oncologists to about 15% involvement of GYN oncologists over the span of 2 years. Part of this publication built on the publication I mentioned earlier by Janot et al. About 1.5 years ago at this point, where they classified cesarean delivery into 3: standard, specialist, and multidisciplinary. What we did, and what was, I think, lacking from that publication, as wonderful as it was actually naming the providers in a department to say who is okay to perform these procedures and what is the expected surgical ability of that provider. And here, I think this kind of helped us create the parameters for what are we able to handle as a COS team who are all obstetricians, and where do we need to call a GYN oncologist. And because stages 3A, B, and C of placenta creta, or a more general term for that is any percreta, are so rare, and they really are rare when you're dealing with the cretas on a regular basis. I think that was where we said, okay, if there is evidence of bladder invasion on ultrasound in the antepartum period, or when you open the abdomen and there is clearly a placenta percreta protruding through the level of the uterine serosa, that is where we draw the line and call in our GYN oncologist. Again, we don't want to not have them as a tool, especially for patient safety, but they're not needed at the other 80–85% of cases that they were previously called in for. So standard cesarean delivery, we said obstetrical hospitalists with less than 5 years of experience, or generalists at any level. Their surgical abilities are expected to be optimizing preoperative hemoglobin, management of acute blood loss, including the use, of course, of uterotonic, TXA, hemostatic sutures, Bacri, Jada device, and cell saver. The level 2 providers, or the level 2 cesarean delivery or specialist cesarean delivery, are those cases with an anterior placenta previa, which just by statistics has a higher chance of actually being an undiagnosed accreta, high order repeat cesarean delivery of more than 4, obstructive fibroids, or a patient consenting for a cesarean myomectomy, which we also do at our institution. And going into the case knowing there will be an obstetrical hysterectomy, but it's due to the, I would say, the lower of the two grades for PAS. These people are experienced hospitalists with more than 5 years of experience that have had repeated exposure to complex surgical cases. It's also maternal fetal medicine specialists who have taken the time and have spent the time in the OR, and are dealing with placenta accreta, both diagnosing it on ultrasound, but then actually performing the surgeries in real time. And these people are able to perform any surgical intervention the level 1 can perform, with additionally the steps needed to perform and lead a cesarean hysterectomy. They're able to make difficult intraop decisions, such as when a simple cesarean hysterectomy would be needed, or when a myoma would be needed to be excised. They're comfortable with managing greater than usual blood loss, and they're able to manage complex cases in the postpartum period, which I think is critical here. You know, the role of the COS team doesn't end with skin. It ends with patient going home on post-op day 3, hopefully, with minimal blood loss, or even if it's not minimal blood loss, they know what is needed for the ICU admission, for the post-ICU admission. I can't stress enough how important this postpartum period care is, especially for us in our institution. We really stay involved until the patient is discharged from the hospital. And then the level 3, or the multidisciplinary cesarean delivery, is those high-grade PASs or the placenta procretas, where we call in our GYN oncologist, even our urologist or urogynecologist, to come place stents in before the case, etc. This usually involves difficult pelvic dissection, you know, due to either neovascularization or placenta invasion. And I think this is a case where we're expecting massive blood loss. And again, while we're writing all this, we're realizing that so much of the morbidity is surgical, and it got us to start thinking about, is there an alternative to performing the hysterectomy? You know, a big shout out to the Pan American Society for Placenta Accreta Spectrum. If you're not familiar, they're a wonderful organization that we joined about 1.5 years ago, and are really happy to be a part of. They do amazing work when it comes to accreta care and research. And I think they're 95% of them are MFMs who have their own accreta program in different places of the country. Some of their work, specifically Dr. Karen Fox, and Dr. Anderson in Utah, have really started the conversation around conservative management, and evidence-based care for placenta accreta. And if you have an opportunity to hear them speak, they're very passionate about this, and I think they're really trying to push all of us who are involved in accreta care, to take a step back and think about what we could be doing better, and are there other ways of management. Part of the conversation that is going on in the obstetrical or MFM groups that deal with accretas is, you know, number one, the FIGO staging. Why hasn't it taken off? What are the barriers to implementing this on a regular basis? And when are we going to start dividing or examining, investigating care based on the FIGO staging, which again, that's what it was really created for. The second, I think, hot topic that people are talking about is doing a better job in predicting morbidity for PAS. The role and benefits of multidisciplinary care. What is the role of IR? What are we doing for blood loss interventions? How can we perfect that process, as we've all been in rooms where the iliacs are ballooned or ligated with gel foam, and you still are leaving the case with 6-liter blood loss. And finally, and I think probably the thing that's getting most attention right now, is the role of conservative management. So I'm not going to talk a lot about multidisciplinary care, because there's really a lot on multidisciplinary care, and everyone who's examined it and every part of the world has shown that multidisciplinary care decreases morbidity when it comes to placenta accreta. Just a quick example of, I think, a very kind of easy to digest analysis of pre-multidisciplinary team to post multidisciplinary team. The big things that we look at in terms of blood loss and transfusion are all decreased in this group that does a fair amount of accreta surgeries in, I think they're in China. So really, conservative management, when we talk about it, I think that we need to make an important distinction about how we approach the research that's out there about conservative management, and really defining our primary outcome. Are we here to reduce morbidity, or are we here to preserve fertility? And the reason I make that distinction is because the expectations going into the surgery for preservation of uterus, for fertility, the counseling around it needs to be done in a very different way than if I'm just saying that removing the uterus will probably cause more blood loss, potentially damage to surrounding structures, etc. Where if I'm saying, we're keeping the uterus because the patient wants to have another child, the numbers are significantly different, and I think that's why the distinction here really needs to be made. So just to kind of give you a glimpse of where this is happening, not in a whole lot of places. A couple of places on the West Coast, I think us and Maryland have a conservative management protocol. I know Columbia did, and they were in a unique situation where the person doing that was a GYN oncologist. He's no longer there, so I haven't heard of a successful conservative management case there in a while. And then there's a group in France where most of the research around conservative management is coming out from. So this group in France published the PROCRETA trial, where they looked at conservative management versus cesarean hysterectomy. As far as I know, it's the only prospective trial that looked at something like this. And what they were able to show is 86 women had conservative management, 62 had cesarean hysterectomies. The primary outcome, which was transfusion or need for transfusion. So the primary outcome occurred in 14 of the 86 women, and I think it was transfusion of more than 4 units. So it occurred in 14 of 86 in the conservative management group, which was about 16%, and in 36 of 61 in the cesarean hysterectomy group, so almost 60%. So a very large difference there in terms of the need for massive transfusion. The rates of hysterectomy, estimated blood loss exceeding 3,000, organ injury, and non-postpartum related hemorrhage were all lower in the conservative management group compared to cesarean hysterectomy. The rates of embolization and endometritis were higher in the conservative management group. Now, taking a different view with the same population, they looked at fertility and pregnancy outcomes following conservative treatment for placenta accreta. So of those patients, they had 27 who wanted more children, same 86 from the first study. 24 of them had 34 pregnancies, which ended with 21 third trimester deliveries, 1 ectopic, 2 abortions, and 10 SABs. The mean time for conception was about 17 months, and all 21 deliveries had resulted in healthy babies after 34 weeks of gestation. The rate of placenta accreta recurrence was about 30%, and the rate of postpartum hemorrhage was about 20%. There are different approaches to conservative management. I can tell you what we're doing in a minute, but what's out there is there's a lot out there about conservative management, and different people do it slightly differently. This is again Dr. Calvecchi down in South America. He's doing these one-step conservative management cases where he has a set of criteria. For example, the bladder needs to or can be surgically separated from the uterus. There's at least 2 centimeters of healthy myometrium above the cervix, and the size of the affected myometrium of accreta is less than 50% of the axial circumference of the uterus. These are the steps. I'm not going to, for the sake of time, I'm not going to go over each one, but I think the illustration does a good job. So obviously you enter above the placenta, you get pedicle vascular control and hemostasis, and then you actually resect the affected part of the uterus and then reconstruct it. What we found is, after diving into the whole discussion of conservative management, is that nobody looked at this on a meta-analysis from a meta-analysis point of view. So we published this again last year, looking at surgical morbidity following planned hysterectomy versus conservative management for placenta accreta spectrum. And what we found was, in every single one of our categories, being ICU admissions, DIC, bladder injury, estimated blood loss, and transfusion, were all lower in the conservative management group. And the conservative management group here included studies that both left the placenta in situ untouched, and those who had conducted studies like Dr. Calvecchi, where there's an actual resection and reconstruction. So this pushed us to finally put an 11-page document out to our department talking about accreta care in general, but also highlighting the need for conservative management. And what we do is we follow the protocol that came out of Duke, looking at targeted placental vessel embolization. So what that really is talking about is a cesarean delivery that happens in a hybrid room where femoral vascular access is established before the delivery of the baby. Once the delivery of the baby occurs, IR then embolizes specific vessels feeding the placenta, and then the placenta is left in situ. The Duke protocol also had several patients who had a delayed hysterectomy in their group, but by us we do simple embolization followed by leaving the placenta in situ. And I think their numbers were impressive. They had a 4-group algorithm scheduled before the algorithm, scheduled not on algorithm, and then unscheduled, both per algorithm and off algorithm. And what they saw is that the patients that were scheduled known accretas coming in on and being treated by the algorithm, and the idea was open the abdomen, take a look, and then decide if the patient is an appropriate candidate to pursue a conservative management algorithm. They were able to delay hysterectomy in almost 60% of their patients, which led to a dramatically lower blood loss compared to the other groups. So for conclusion, our focus is first and foremost needs to be reducing unnecessary cesareans. And this is, I think, a much broader conversation that some of the surgical programs around the country are tackling. And I'll give you a quick example. the Complex Obstetrical Surgery Fellowship, which is, I think, the only one right now, which is in Toronto, part of their training and part of their curriculum is actually reintroducing forceps into their training. Risk-reducing planning and delivery. Who is there? What are we using? Who's the surgeon? Really thinking about the right patient, the right surgery, and the right team to manage it. Research, still going, still ongoing, still a lot, I think, to kind of unmask and tackle. We need to better define our morbidity standards, which has not yet been done, and standardizing approach. I think there are pockets of places around the world where people are doing a specific thing for example, conservative management, but those are hard to replicate into other institutions. And then, I think there's still some stuff to be uncovered regarding the pathophysiology of placenta accreta, and potentially even finding some more novel predictors for increased morbidity and mortality. And if you don't have, and I'll leave some time for questions.
Dr. Futterman, thank you so much for this presentation. We have a comment in the chat from Dr. Gottschall, one of our GYN oncology fellows. It's difficult to address this difficulty in performing cesarean hysterectomy without calling the gyn-onc when OBGYNs are performing so many fewer total abdominal hysterectomies. There's so many more minimally invasive hysterectomies that general OBGYNs have less familiarity. Would you like to comment on that?
Yeah, I think that's, that's the real chicken or the egg kind of scenario. I think absolutely people, and we discussed this during the presentation also, people are leaving residency less confident in their ability to perform cesarean to perform open hysterectomies. They're getting less training on it, and they don't feel comfortable doing it, especially not in an uncontrolled setting where there's blood loss and hypervascularity because of a pregnancy. With that said, I think there are probably, especially in tertiary care center, there are people who have had the surgical experience who are not GYN oncologists who can probably reduce that burden by being the first call, being that person who is called to come into the OR when there is a problem before jumping the gun and calling the GYN oncologist. In our institution, it's really, when we published this paper almost 1.5 years ago, talking about role and role definition, we were thinking that, we'll be on the safe side, we'll leave the procretas to the GYN oncologist. Since then, the GYN, we've had, I think, two procretas since true procretas since this publication, and the GYN oncologist didn't have to come to those cases either. I think it's about finding the right people who have the surgical expertise, who are passionate about accreta care, who are passionate about complex OB surgery, and gradually, and we discussed this in our publication, how do we bring the people who are passionate about this kind of care and surgical involvement, how do we bring them up to the level where they feel confident they can lead these procedures, and have the GYN oncologist be there for the first 5 or 10 or whenever both sides feel like, okay, I can do this without you here, and I can call you if there's a problem. So I think there needs to be the pendulum has shifted so far towards GYN oncology, and I think we rely on them, I think, too much, that it's not fair to them, it's not fair to their patients. And there's an opportunity here with this emerging new conversation about how MFMs and maybe even hospitalists can resume some of those responsibilities and be that first line of defense.
I see that Dr. Rosenfeld has her hand up.
Good morning. Thank you so much for a wonderful presentation. My question for you is, could you talk a little bit about what steps you took as a fellow and new attending to become more comfortable doing these accreta cases?
So I think that and you know this because we trained in the same place, but what kind of the trigger for me was the caseload in residency, and as a chief, being involved in probably a dozen cases of accretas with GYN oncology not always available to come in and help for these accreta cases. And I think that left me going into fellowship thinking that this is something that I would really love to do on a regular basis. And when I got to Maimonides, I found this vacancy. I found exactly what the literature is describing. GYN oncologists who are being pulled into the OR, who don't want to be there, who are dying for someone else to take that responsibility. So the conversation started in my first year of fellowship was, let me go into the OR with a GYN oncologist to do this case. We'll do a couple together, then you'll take a step back, then I'll do the cases. And then eventually by the middle of my second year, I was doing the cases without a GYN oncologist in the room. The way we're credentialed in Maimonides allowed that because you take calls as an attending. I had attending privileges. I am signed off on open hysterectomies like majority of OBGYN providers are. So there was really no issue in terms of privileges, which I think kind of broke that mindset of, oh, a GYN oncologist has to be there for every hysterectomy, for every obstetrical hysterectomy. So by the middle of my second year, the accreta cases were coming to me through fellow clinic. I always had backup if needed, but our outcomes were really good. We didn't have to call a GYN oncologist, I think, for the duration of my time in fellowship, into the OR to help with the hysterectomy. And eventually it just took off. And I was lucky enough that there were two very experienced hospitalists that joined our hospital at around the same time, also really wanted to get involved with accreta care. And we formed this group where we would operate together, knowing that between the two of us, we're probably, to get, again, combined skills, we're probably as close to a GYN oncologist as we can get without doing a GYN oncology fellowship. In terms of performing an open hysterectomy. I'm not talking about lymph nodes, stripping, all those fun things that GYN oncologists do. No, we don't do that. But and I think in our mind we started to push ourselves, knowing that backup is available, but let's try to tackle this, and if we need help, we'll call for it.
Thank you. I see that Dr. Sharma has her hand up.
I was going to echo a little bit of what you said already. I think you, Dr. Futterman, amazing talk, and you hit the nail on the head in your conclusion slide that we need to be really mindful of that first C-section and bringing those skills back. A lot of it is on the mentors in residency, bringing those operative delivery skills, making sure we're following the induction protocols, trying to reduce the C-section rate, bringing that breech delivery skill, external cephalic version. I mean, you name it. We can try to reduce that first C-section, and also, talking about TOLAC and things like that. But the question I have for you is for the conservative management protocol that you follow. So I have seen from whatever protocols I have seen in different institutions, the delayed hysterectomy rate in those patients is fairly high, to the tune of like 40 to 50%, sometimes even higher. What is your experience? And then I want to also know the rate of sepsis and endometritis in those cases that you've seen.
So in our institution, and again, I officially started as an attending in September. I've been doing the cases for about 2.5 years now. We didn't establish our protocol till about November of last year. So I was working on it during in my third year of fellowship. So just to, very honestly put on the table, we've had 4 so far that were successful. So our N is very small, but we've had no rates of endometritis. We've had no need for delayed hysterectomy. One patient opted eventually to undergo a hysterectomy, but that was because of prior pelvic pain issues before the pregnancy. So eventually was taken for a laparoscopic hysterectomy. But we haven't had those complications. I think the difficulty around the numbers of sepsis, endometritis, delayed hysterectomy, the difficulty in really making a broad statement about it is, again, it's so not standardized between institutions. Every place does something completely different. Like the group in France, I heard a talk by them 2 years ago. Their protocol is really something that nobody else does in the United States. Their patients stay in the hospital for about 2 to 3 weeks and get 2 weeks of IV antibiotics. And, I think their rates of delayed hysterectomy were actually the highest I've seen. I think the areas in the country where IR is being used on a regular basis for iliac embolization, also there's very mixed numbers. The people are like, no, we have to embolize the iliacs before we start. But if you look at the numbers, what does that really add? You're able to preserve maybe another 500 ml on average. So it's very hard to make, I think, a broad statement. I think we're seeing the different protocols being copied from institution to institution, and people are adapting. And I think 5 to 8 years from now, I think we'll have much better data. We also have not had a randomized controlled trial comparing conservative management to planned hysterectomy yet. There are talks to do this through the PAS squared group as a multi-center study. Some of us are trying to put something together potentially for an NIH funding for a feasibility trial, but this is going to take some time. It's also, we say 1 in 250 deliveries, but the truth is that even in places like Duke and Utah, they're not doing more than 14 cases a year, I would say, is probably, so it's going to take time. It's going to take a lot of institutions to kind of jump in and follow a standardized protocol, which is going to be hard because everyone's very opinionated about their conservative management protocol.
Dr. Futterman, unfortunately, we're out of time, but thank you for this great talk.
Thank you so much for having me.
Yes, thank you so much. So we're going to end it here. I wish everyone a safe and productive day.